Good afternoon, everyone. My name's Gemma Smith, and I am the Neuro Rehab and Stroke Network Facilitator. Hopefully you're all attended because you want to join the Neurogenic Bladder Management webinar, and we're joined today by Michelle Hogan-Tricks, who will kindly deliver this. Just to let you know, a few changes since we last met. We now have a new network name, so for those of you that don't know, we've recently merged with the Stroke Network, so we now are the Greater Manchester Neuro Rehab and Stroke Integrated Delivery Network. We also have a new Twitter feed, so we are at GMNISDN, and we still currently are running the two websites, but they are due to merge in November, fingers crossed. So for any future events, still do go on our individual websites for now, and we'll let you know of any upcoming changes. Similar to previous events, we've got a live Q&A at the end of the webinar, and you can pose any questions to Michelle and the team by just entering and accessing the Q&A box. This recording will be sent out after the session, and also you have the potential to access certificates. So if you do email Lisa, she'll be happy to send these across. Please do tweet us at GMNISDN, and do let us know what you thought about today's event, and if you do have any recommendations for future training events as well. As I mentioned, we've got a few events coming up over the next few weeks before Christmas, so do have a look on our website. There are some stroke webinars, and also we've got neurogenic bowel management, and we also have a masterclass on MND. So just to say thank you all for attending, and I'll hand you over to Michelle, who'll kindly start with today's masterclass.
Hello, thank you for joining me today. We are going to talk about neurogenic bladder. So my name is Michelle Hogan-Tricks, and I am the neuroclinical lead at Coloplast. My background is I'm a specialist nurse in neuro. I've worked at the National Hospital for Neurology and Neurosurgery all of my career, and that was 23 years or so. So I've got quite a lot of neuro experience. So as I said, today we're going to talk through neurogenic bladder. We're just going to talk through what causes neurogenic bladder, look at some anatomy and physiology, and then look at how we might manage a neurogenic bladder. So first slide here is just looking at causes. So what can cause neurogenic bladder? Well, one of the biggest causes is spinal cord injury, and in fact anyone that has a spinal cord injury is highly likely to be experiencing a neurogenic bladder. Next down on the list there is MS, and in the UK we quote figures. If you look at the MS Trust and Society, you'll see that figures are quoted that around 70% of patients with MS will experience a neurogenic bladder. In fact, we think we're probably underreporting that, because if you look at European data and international data in general, they will quote figures more like 90%. So all of your MS patients are highly likely to be experiencing or will have a neurogenic bladder at some point throughout their journey. Other things that can cause neurogenic bladder: brain injury, tumour, tumour in your brain or your spinal cord, any of your neuroinflammatory conditions, stroke, spina bifida, bleed, essentially anything that's going to cause an insult or damage to anywhere along in your brain or your spinal cord puts you at risk of neurogenic bladder. Now this is just an image for me to try and explain to you that if you look on the right hand side, we've got a bladder and a tick, and that's just to say that actually in neurogenic bladder, your bladder anatomy itself is working. So there's nothing wrong with your detrusor muscle, for example, your bladder, that's working fine, unless you have comorbidities. But the problem with the neurogenic bladder is there is an issue with your brain or your spinal cord or both, so that the innervation, the nerve innervation to your bladder is dysfunctioning. This is just an image just to remind us of what normal urination, normal micturition looks like. So if we look at the left-hand side of the screen, you've got your bladder there that's nicely filling. Just above your bladder, you've got your ureters, which, if you remember, they're going up to your kidneys, and that's important to remember this for later on in the presentation. And then you've got that pink bar going across, which is your external bladder sphincter and your urethra. And then if we move to the middle picture, you can see that this person is, or this diagram is showing somebody who is starting to pass urine. So what happens is that bladder that was in a relaxed state when we were holding our urine in has now started to contract down. Our external sphincter has relaxed and has released and opened, and we are able to pass urine in a controlled environment, in a toilet, under our control, with a nicely contracting bladder and a synchronized sphincter that's opening to release the urine. And then you see it's on the third picture, it's just our bladder muscle is working even harder to drain that bladder completely. And it's all nicely controlled and synchronized. We're just going to move on slightly from the bladder over to spinal, brain and spine orientation. There is no brain on this image, but essentially I'm sure you all know that the brain is there just above the spinal cord, so imagine that it's there. And this picture is showing, if you look on the two outer lines, the lighter grey lines or images, let's say, that's your bone, that's the bone part of your spinal column. And then if you move in, you'll see that the white kind of canal, let's say, it does look like a canal, I would say, that white is depicting where your CSF will be, so that's your cerebral spinal fluid, and that is a liquid that's cushioning your brain, that will go around your brain as well, and your spinal cord. It's causing some protection there, and also it's feeding your brain and your spinal cord too. And then if you come right to the center of that picture, you'll see like a sigmoid shaped dark grey S, which is depicting your spinal canal. So that your spinal canal, which is attached to your brain, are your central nervous system, and it's important that you understand the difference here. So your brain and your spinal cord, sorry, not spinal canal, your spinal cord, are your central nervous system. And then if you look at the numbers all the way from C1 at the top all the way down, you will see at each level, at each exit point there off of your spinal cord, you'll see that you've got this lighter grey line coming off. And these are your peripheral nerves, okay? So that's where your central nervous system changes into a peripheral nerve. And if I take your eyes right down to the bottom, you'll see that the spinal cord tapers. And this is it's a cone shape. And if you look at where T12 is, just near that cone shape, you'll see the T12 is a slightly darker grey. There's lots of grey going on here. At that level between T12 and L2, and it's slightly different on all of us because we're all just slightly different, is something called your conus. And you have probably worked out the reason it's called your conus is because at this point your spinal cord, your central nervous system, becomes a cone shape, and off of the bottom of that is a whole big bunch of peripheral nerves which are called your cauda equina. And it's called the cauda equina because if you think equine, equina, horse, cauda, tail. So it looks like a horse's tail, your cauda equina. Okay. Oops, wrong way. So what I want to show you here is you'll see the explosion that I've just popped onto the slide at the T1 level. This is just to show you that this explosion is just showing an insult to our central nervous system. Okay, so that could be a tumour, it could be a bleed, it could be an MS plaque, anything that's causing some compression to our spinal cord, or that could also have been in our brain. So you can see the messages coming from the brain down the spinal cord are only going to get to T1. on this image. Now that insult could have been higher up, it could be lower down, it could be in the brain itself. So you can work out now, if you need messages to go from our brain down our spinal cord all the way down to these nerves around the T12 region, out to our bladder, or it could be, you know, down to the lumbar region to our legs or our feet, you can see how these messages are going to get either completely not get through or become interrupted and partially get through. So you can see now how messages running down the spinal column, if there's an insult to that spinal column or the brain, they get interrupted. Okay? And it's important to have that in your mind, because when we look at peripheral nerves, so for example, if I was to take just above that explosion, if we were to take the peripheral nerve at the C7 level, which is one of the nerves that only, once it becomes a peripheral nerve and it exits your central nervous system, it's only now dealing with information that is going down to our arm and our hands, for C7 as an example. Okay, so you can see now, actually, if you had an injury at the T1 level, you're going to be able to perfectly function to C7 and above, but anything below that level, there's going to be problems. Okay, so we're just going to move on slightly, and we're going to look at the different types of neurogenic bladder. And this is the same, by the way, for bowel. So anything I'm saying today about bladder, you can kind of translate into bowel. There is going to be another webinar on bowels in 2 weeks' time, which would be great if you guys can join. But bear in mind, this is kind of bladder and bowel when I talk. So you have got mainly two types. You either are going to present with a neurogenic reflexive bladder or bowel, or an areflexive, and you can see here for reflexive I've put spastic in brackets because it's reflexing. Okay, so it's like a spastic bladder or bowel. And then below the T12 to L2 conus level, we have an areflexive bladder or bowel, and otherwise known as a flaccid. So it's flaccid, it's floppy, there is no spasm there. Okay, and then you'll see in the middle around that conus level, so that's T12 to L2, and again it's going to be slightly different for all of us because our conuses will lie higher or lower, but roughly that's the region for the vast majority of us. You're going to present with a mixed picture, and that's because you've got around this area you've got your spinal, your central nerves changing to peripheral nerves, and there's also a reflex arc at this area which controls the bladder spasms, or your bladder spasming, contracting and relaxing. So we're going to get onto that in the next slide. So this is as complex as it gets, I promise. So again, this picture here, you can see we've got a brain and a spinal cord, and as you all know, and we've just talked about, messages from anywhere. I mean, we're talking bladder today, but really for any message, as you know, it's going to come from your bladder or from your hand. For me to do this, there is a message that's going from my brain down my spinal cord into my hand and back to allow me to make my hand function. Same with your bladder. You know, when you're a baby, you just pee into a nappy. But as we get older, we learn to control that, and when you're all busy on a busy ward or running around in the community and you really need to pee, you don't just wet yourself. Hopefully for most of us we manage to hold it, and under a controlled environment we pass urine into a toilet at an appropriate time. So if you look now at your brain and your spinal cord, you can see when you get down to, on the left hand side, you can see it says T10 to L2. Really, it's more around the T12 to L2 level that we're talking about. This is your conus region, remember? So you'll see this blue kind of loop that's going from our spinal cord to the bladder. And this is a reflex arc. Okay, so this reflex arc is working to allow It's various different nerves that make this reflex arc up. You don't need to remember all the nerves, you just really need to remember that there's a reflex arc at this level. And that's what allows our bladder and our sphincters to contract and relax under the control of the brain in a nice controlled manner. Now, if we get back to another explosion, so you might be saying to yourself, okay, so why is it that we have a reflexive bladder if it's above the level of T12? We have a flaccid bladder if it's below, and we've got this mixed picture if it's somewhere in the middle. Well, I'm hoping to explain this to you now. So you can see the explosion that's just appeared here. Again, that could be a spinal stroke, it could be a tumour, it could be a slipped disc, or a disc herniation, as we should call it. And this explosion could be anywhere above T12, okay? So you can see if you've got damage above T12, the messages are going from your brain down that spinal cord. Oh, there's an interruption. This level looks like it's probably around T1. But what you can see is still completely intact is the reflex arc, okay? So that reflex arc is still completely intact because a reflex arc doesn't have to, the messages don't go the whole way up to the brain. An example of a reflex arc would be if someone was to stick a pin in your finger, you would pull your finger away really, really quickly. And that's an example of a pain reflex arc, because the time it takes, it's almost like a protective thing. The time it takes for that message to get to your brain and back would be quite a long time, so the reflex arc will make it happen quicker. However, this reflex arc, yes, it is still there and it's still present, but it's now working without its master control, its brain. So I like to think about this, I like analogies, and I like to think about this as our brain being parents. And the spinal cord and this reflex arc in particular are like the teenagers, okay? So the parents have gone off on a lovely cruise, they've been working hard all year, and they've left the teenagers at home. So the teenagers can still function, but they're probably functioning, or not all teenagers, of course. Some teenagers might be functioning in a slightly different way than the parents, the brain would like. So these particular teenagers have decided to have a nice party. They've their friend's sick on the lovely velvet sofa. They've broken up the roses in the garden. They're basically functioning, but they're not functioning in the way that they should. So this reflex arc is now functioning, but it's spasming, it's relaxing, it's spasming. As you know, when your bladder contracts, then our external sphincter should relax or open to allow us to pass urine. Often in these spasmy bladders, there's a very high pressure. So this bladder is going to be contracting and the external sphincter might stay closed. Remember, we talked about those ureters that are going up to the kidneys. So you can imagine now, if you've got a closed sphincter, you've got a bladder that's spasming, it's under high pressure. That urine in that bladder has got nowhere else to go but to backflow up to the kidneys. So these bladders are really quite dangerous, these spasming bladders. They can cause damage to the kidneys. And I mean, apart from the fact that they're hugely irritating for patients, and we'll get on to that, but they're often missed, okay? And that's the one thing that I want to get through to you, that spasming bladders are often missed. And we're going to get to that in a minute. Now I just want you to pretend that that first blue insult isn't there, and we've got this grey one now. So you can see now, if you have got an injury that is at the conus level, that T12 level, or below it, you can see how we've now knocked out the reflex arc. Yeah, so this reflex arc is now being impacted. So remember, I said to you, if you've got an injury on the conus, so it's slightly different for everybody, but anywhere between T12 to L2, you might get this mixed picture. So obviously my big explosion here has obliterated everything, but actually in reality it could be that it's just partially knocking out some of the messaging down that spinal cord. So at that level you might get a bit of a mix, and you've still got some information getting through. But as you get down lower, you anything, if you have an injury lower than your conus, you are definitely going to have knocked out your reflex arc, and that's it, completely flaccid bladder. Okay, so just a kind of recap on all of that. A reflexive bladder is a spasming bladder, a spastic bladder. One way that you can work this out, and some of you might feel comfortable to do this and some of you may not feel comfortable to do it, a PR examination. So for the nurses on the call, you should all be able to, you know, have a go at this. Obviously you need to gain consent from your patient. Some trusts ask for you to be chaperoned to do PR examinations now. You just need to check your kind of local policy on that. But if you were to do a PR examination, just as you would before you were to give a suppository, you ask your patient to squeeze around your finger. Make sure that it is actually that you're not feeling their butt cheeks squeezing around your hand, but you are actually feeling their anus squeezing, their external sphincter. So you can ask them if they can squeeze. Now what you tend to find, and again the nurses that are used to doing PRs, you know yourself, as soon as you start to try to examine or do a PR examination, you see that you start to get a spasm. You can also do a light pinprick around that region, so you can take a neuro tip, and if you prick around the S2-3 segments, you can see the it's actually called an anal wink. You can see that happening. But a PR examination, you can usually feel whether you have got a flaccid rectum or whether someone is able to squeeze around your finger. You can ask them to squeeze, so that's a voluntary anal contraction, but generally you might get some involuntary spasms there as well. So remember I said bladder and bowel usually come hand in hand. So this is a good way for you to work out if somebody has got a spasm in bladder or a reflexive or an areflexive, a flaccid bladder. But also, of course, excuse me, you're looking at, you know, you're looking at the level of injury of these patients. And again, if you're working, so if it's a brain injury, then they're very, very, very likely to be having a reflexive bladder. If it's someone who's called a requiner, then you're starting to think, okay, what level is this injury? So you've got, you know, a few different ways to be thinking, is this reflexive, is this areflexive? And again, this picture here is just showing what we've just been through, really. This is a brain with a spinal cord, and you can see if you come halfway down, there's like the break in the spinal cord, and that's just showing again that if you have damage, so you can see all of these MRI images that are showing lumps and bumps in brains, and I think C there is probably showing you an aneurysm. All the way down to this spinal column here, I, which is showing it looks like it could be a tumour or some kind of inflammation, and that's all above the conus, so you're going to get a spasm in bladder, and you can see the bladder here has got all of these arrows which are showing that this bladder is a spasmy bladder. So again, to remind you, that's the level of injury above T12. You're going to get this bladder that's involuntary contracting. Okay, so these patients often feel the need. So this is again where your investigation skills are starting to come out. So these patients are often going to feel the need to urinate quite often. They won't have much in their bladder, but they will be getting that spasm, that urge to pee. There's going to be a lack of coordination, so they might get an urge to pee, but they can't pee because their external sphincter is closed, or then they might get an urge to pee and they might have an accident very, very quickly. This bladder is just kind of being an irritant and spasming and causing people to really, it's not particularly nice, to be honest. And then the other thing to bear in mind, which I did comment on and I will say again, is if you've got this contracting bladder which is causing a pressure and you've got your external sphincter closed, then these are the patients where they are really at risk of kidney damage, which can be permanent, and you know, none of us want to be causing more damage to our patients. So how do we manage this? Well, as I said before, these are the patients that are quite often missed, and the reason they're missed is they'll go on to a unit which may not be a specialist neuro unit, for example, who have specialist staff who really understand a neurogenic bladder, and a junior member of staff, doctor, nurse, may come and say, have you passed urine? Because most people know, okay, we need to, you know, make sure that the bladder is working, but what they'll say is, have you passed urine? Oh yes, I've passed urine, and they won't dig further. So of course these are your patients that may well pass urine. They might pass a small amount of urine, but they are likely to be retaining quite a bit of urine in their bladder. And again, if you've got that urine that's being retained in there, then it can backflow up to the kidneys. And also, if we're retaining stale urine in our bladder for more than 12 hours, then we all know that that puts you at risk of recurrent urine infections as well. Okay, so the management of these patients, what I would ask you all to do, and I appreciate we've got some community staff on the call, and I'm not sure whether you do have bladder scanners or not, but if you don't, then your role probably is to just be thinking, oh, could this be my patient, and do I need to refer them on to somewhere to get this checked? If you do have a bladder scanner, then what you need to do is do post-void residual scans. So you're asking that patient to pass urine into something that you can measure, and then you're measuring the amount of urine that they've passed, and then depending on your local policy, or if you don't have a policy, there are a few different ways you can do this. I think lots and lots of people just use a volume of 100 to 150 mils. So if that patient is retaining more than 100 mils of urine, then I would be thinking, okay, I need to refer them on, or can I manage this myself? And depending on who you are on the call, you'll be at different stages of that line. Where I used to work at Queen Square, the National Hospital, we would use a percentage. And the reason why we used a percentage is because as I've just explained to you, many of these patients have this spasm in bladder, so they may actually only pass out 100 mils of urine. So you can see if someone's passed 100 mils of urine, but they're retaining 100 or 150, they're retaining 50% or more of what they've voided out. That's just not normal. So we would use a percentage, and we would say that patients are allowed to keep less than 20% or less of what they voided. So for example, if they voided out 100 mils, then they'd be allowed to have 20 mils in their bladder. If they voided 200 mils, they'd be allowed to have 40 mils in their bladder, etc. And I appreciate for many of you that you may not want to get that kind of specialist into it. So generally speaking, I think most people will agree that residual volumes of around 100 up to 150 are probably acceptable, but I would certainly be keeping an eye on this patient. So we've talked about spasming. So some of these patients will be, an antimuscarinic or an anticholinergic will help to calm their bladder down and just prevent that constant spasm and irritation. Again, this might be something you're going to have to, in the community, speak to their GP about, or get your continence service involved in, or if you are a nurse prescriber and comfortable to do that yourself, then it's something to think about. Educate these patients. Many of them, as you know, they'll just dehydrate themselves completely because they're like, oh, the more I drink, the more I need to pee. And we know that dehydrating a bladder is just putting you at risk of urine infections, etc. So educating them that actually, for some of these patients, drinking a little bit more might actually help calm this down. However, for others, if they genuinely are drinking loads and loads and loads and drinking late into the night, then you may want to educate them on that. Educating them on the fact that caffeine, alcohol, smoking, fizzy drinks, spicy food for some people are all irritants to our bladder, and it can be different for different people, so just getting them to keep a bit of a diary can help. And then finally, patients that are not emptying their bladder successfully need to be taught intermittent self-catheterization, or intermittent catheterization, I should say. And that is for that is the gold standard here. Okay, so indwelling and suprapubic catheters should only be used. They should not be first line. They should only be used when patients cannot manage on intermittent catheterization. So for those of you who are in the community, I would say really have a think about some of your patients now who have got indwelling catheters in, suprapubic catheters. Is that appropriate for them? Start to be an investigator and think, does this patient have good function with their hands, or reasonable function with their hands? Is this patient cognitively aware enough to be able to self-catheterize, either self-catheterize, or some people may have a good carer or a partner that is prepared to do that for them. I appreciate that does add in an extra layer, but again, that's for you to sort of make that judgment call. And if you've got a patient that's there with an indwelling or a suprapubic catheter that you're now thinking, actually, this patient, I'm not really sure why they've got this in, then I'm hoping that for some of you, you might be starting to think, oh, okay, Mrs. X or Mr. whoever, perhaps we could look at swapping this out. And there's all sorts of reasons why we're much better doing ISC or intermittent catheterizations as opposed to indwellings, and we'll come to that in a second. So I just wanted to move on quickly to the areflexive, the flaccid bladder. Okay, so these are the ones with the neurological level of injury that's below T12. So you're mainly going to be looking at, well, not mainly, but often these are a lot of your caudal requiner patients. If you've got an MS patient that's got multiple plaques, they might be experiencing this, or they might have a bit of a mixed picture. A very common prostate metastatic disease would be to the lumbar region of your spine. So these patients might be having areflexive type bladders. So you can see the first picture here on the left is a bladder that's nicely filling, and this bladder is reasonably full. If you look to the second picture, you'll see the two dots. Now that's your, as most of you will know, that's your trigone region. And at that level, that's when we're all busy doing our ward rounds or running from one patient to the next, and you're getting that feeling of, oh, I need to pee. You've actually not got that much in your bladder at that point, probably, I don't know, around 250 mils, depending on your size and your anatomy. But we often ignore that. And then we start to get more and more, I need to pee, oh gosh, I really need to pee. And that's as our bladder is filling, really like this first bladder. And you're now getting feedback from your bladder muscle, your detrusor muscle, that's being stretched and to the point where you're now like, oh my goodness, I really need to get to a toilet now. So for our areflexive patients, they just don't get that. So their bladder will fill and they will get a painless retention. Okay, and what will happen is their bladder will be full to the point of bursting, and they will then get this overflow dribble of incontinence, or it might be a slightly larger bit of urine that comes out, because what's happening is if we leave these bladders, we are just going to damage that muscle. So remember, for most of these patients, unless they've got a comorbidity, their bladder itself is fine. It's the nerve innervation. So what we don't want to do is miss this. And then if their nerve innervation ever improved, which for the caudal requiners, often they can get some degree of improvement, we've now caused permanent damage to that bladder because we've stretched it too much. So it's really important that we're picking up these patients as well. Okay. So also with your mixed picture, they might get a bladder that fills and it gets to the level of this picture you can see on the top left. And at that point, they get that initial feeling that we would get at the trigone of, oh, maybe I need to have a pee. And you can see at this point, they should really be bursting. Okay, that's just an example of what you might get on a mixed picture. So for your flaccid bladder management, they do tend to be easier to spot, and they don't tend to be the ones that are missed because they're in hospital acutely, and they just can't pee. So often they're picked up. The mixed ones might be missed. And again, post-void residual scanning, and if it's more than 100 to 150 mils, or our 20% number that we talked about before, then you really want to be doing intermittent catheterization on these patients. And there aren't really any other solutions for these patients. They can't pee, they can't get the urine out. Even if they can get some of the urine out because they've got a mixed picture, then I would always, if a patient can pee some degree, I would always do a bladder scan to check that they are completely empty in their bladder. And the solution here again is intermittent catheterization. Just to point out, and a watch out for you, is with these patients that fill, and they've got a really full bladder, just be careful. If you can send them to the toilet, I've had experiences where you send them to the toilet, sometimes they either can't pee or they will come back and say, oh yeah, I did pee a bit, because they might have this mixed picture. And then you do a bladder scan and it looks empty. And in particular with the portable bladder scans, which may not be as accurate as the big expensive ones you get in urology units, be careful, because if the bladder is completely full, which they can be with these patients, the bladder scanner doesn't recognise the edges, so it will tell you that the bladder is empty when actually it's completely full. So if you're in any way in doubt and thinking, that doesn't sound quite right to me, do an in-out to check, and you'll be surprised. That happened to me not that long ago, and a patient, it came up on the bladder scanner as completely empty, and actually the patient had over 1,000 mils in his bladder. So just a watch out for you. Yeah, so again, the solution here, gold standard, is intermittent self-catheterization is gold standard. If it's a patient who's got a good carer or a good partner that's prepared to do that for them, then you can still consider intermittent catheterization. And indwelling and suprapubic should only be used on patients that have got very poor hand function or cognitively just can't, wouldn't remember to self-catheterize. Now, obviously, because we're dealing with neuro patients here, there are many patients that use cues. They'll use alarms, they'll use writing things down in their diary, they'll write things up on their calendar. So if it's a patient that's already used to doing that, to remind them to take their drugs, to go to the shop, whatever, if you feel as a clinician that they would cope with having alerts to remember to catheterize, then certainly you can consider intermittent self-catheterization for those as well. And that's again a clinical call on what you feel would be best for that patient. So we talked a lot about the mixed picture as well, and in these it's just a little bit more detective work really. You have to oh, I see that there's a typo there, that should say T12 not T11. You just need to yeah, do a little bit more detection, and you might get this bladder that fills and fills and fills, and then at a very last stage they might think, oh, I need to pee, or they might be able to pee out a little bit and not completely empty their bladder, but they're still likely to have quite prominent bladder dysfunction. I just wanted to put up this MRI scan. I just always think it's nice to be able to visualize what I'm talking about. So if you look at where the spinal cord is, so you've got the bones there that are depicted with the numbers T12, L1, L2. If you move in, you'll see that you've got that really dark image that turns into a cone shape. So that is your conus medullaris, is what it's known as, and that's where it's around that region that you're going to get these mixed pictures. So, does your patient need an IDC or an SPC? So do they need to have an indwelling catheter or a suprapubic catheter? And this brings me back to you guys that are maybe in the community, and you have a patient that's got a catheter in, and you're now thinking, oh gosh, actually, do they really need it? I really like this picture that I've put. This is just an example of one of the catheters that we have at Coloplast, and it's just, you know, she's actually designed, her name is Eve, she's designed to look like a mascara, and, you know, I just kind of think about myself really, and I think if I had a terrible injury and I ended up having to use catheters, obviously that's really tragic for many patients. But if I had, you know, if I was offered an indwelling catheter or a suprapubic catheter, versus this, which is a disposable, catheter, just in terms of my body image, how I feel as a person, my sexuality. I would certainly choose to go down the ISC route. And apart from that, if we take away sexuality, body image, which in my opinion is super important anyway, but we know that indwelling catheters, after having them for 2 weeks, it's kind of 99% likely that you will start to develop UTIs. We know that they cause damage to the bladder. We know that indwelling catheters cause damage to the urethra. They can cause damage to the tip of the penis. Really, after 4 weeks, you start to see that. Pressure ulcers. So there's lots and lots of reasons why we should be considering intermittent catheterization over IDC and SPC. And the reason why I've just put a little picture here of Eve, this is a female catheter, by the way, but you can see, because we are talking neuro patients here, she's been designed so that she's got a nice easy hand function, the shape of her. Also, she doesn't roll away. If you drop her, which a lot of our patients might have, some hand dysesthesia, and also she's designed so that if you were to put her standing upright like this, she stands nicely because of the shape of her. So again, it's about looking at the selection of intermittent catheters and what one's going to work for your patient. Now, some of you will be really used to talking and looking at neurogenic bladders, and some of you may think, oh, that's all great, but I'd really like some cues to really make me kind of hone in on what I should be looking at. So this is just an example of a checklist that we put together for Ayrshire and Arran. We're working quite closely with, we've done a joint project with Ayrshire and Arran MS Service, and we developed a bladder. This also has a bowel part to it, which if you log in 2 weeks, you'll see the other side of this. But these are just things to think about. And we're very happy to, if anyone wants to look at designing a little kind of performer for their patient, or even for themselves to tick, then we're certainly happy to have a look at that with you. But things to think about: urgency, frequency, incontinent episodes, nocturia, the flow stream, the volumes that are passed. Are they having recurrent urine infections? Sensation of bladder filling and when they're passing urine. The impact of the bladder is having on this patient's quality of life. Because this form is designed for patients, we're not using terminology like that. I've just popped that on there for you guys, but depending on who you would want to target something like this, if it's something you wanted to do, obviously you would word it in a different way. And then one of the second to last slide here, I just thought I'd talk a tiny bit around adherence. So the importance of adherence report is hot off the press. It just came out in July. This was written by the Bowel Independent, or the Bowel Interest Group rather. But it is completely, it's completely relevant, really, if we're talking about bladders as well. Professor Anton Emmanuel is a neurogastric specialist, so he's always looking at things from the neuro perspective, and Ben Disney is a general gastro guy that works up in Coventry, or down in Coventry for you guys, up for me. And this report just looked at adherence. So adherence is a new word we're using, as I'm sure you all know, and it's we used to talk about compliance. We don't like to talk about compliance anymore, because that is an assumption that we are telling a patient what to do, whereas adherence is supposed to be more of a two-way thing, and it's a joint decision made with your patient. So the report showed that patients need adequate support from their healthcare professionals. It's really important, especially in those first few weeks, those first few months of a new treatment. So when they wrote this report, they were thinking about transanal irrigation and medication, but I think it's very transferable to starting a patient on intermittent catheterization or drugs or a new regime. It's really important that they can get that regular support, follow-ups within a week, 2 weeks, so that if there's anything that needs tweaking and adapting, we're there to help them as clinicians and to support them through that. It's important that we offer people alternatives, so patient choice is really, really important, and patients should be given full information. So this just makes me think about our patients who have got indwelling catheters in, suprapubic catheters. Have they been informed that actually intermittent catheterization is probably, or not is probably, is gold standard for them? If you look at the UK, the figures show that around 20% of patients that are intermittent, around 20% of patients that can catheterize are appropriate for intermittent catheterization are doing so. So 80%, there are 80% of patients that could intermittently catheterize that aren't. They've been given another IDC or SPC. And if we compare that to France, it's almost flipped on its head. Our neighbours are way more advanced or ahead of us with this. So we really do need to start thinking about it. So patients should be given that choice, and we should explain the rationale, and we should explain why we have given a patient a treatment that we've decided to give them. And of course, adherence is really important. It's important in terms of patient outcome. Patients that adhere to a program that we want them to have as clinicians are likely to be more cost effective on the NHS. So patients who fall off of the program that you write for them are likely to revisit A&E, likely to revisit their GP. There's big cost implications on the NHS on that, and also there's economic cost implications. So patients, I'm sure you'll have heard, patients will often say to you that it's not the fact that I'm in a wheelchair or I have got alterations to my mobility that keeps me in. It's the fact that I pee myself or that I poo myself that keeps me in. Stop working. So then it's got an economic impact as well, and then also the psychological impact on that patient, which is, massively, equally as important as any cost implication. And then to finish up, I just wanted to put this up. How can Coloplast help? Well, we speak about adherence, and I know lots of you are really, really busy, and you might be saying, well, that's great, Michelle, but I don't have the time to give them a call after starting a new intermittent catheter regime, and they'll just get an appointment in clinic in 3 months' time, or I'll just tell them to call me if there's an issue. But I'm going to do a shout out on our outstanding CQC outstanding nursing service. We've got a massive nursing service at Coloplast. I'm really proud and pleased to say that a lot of our senior staff are nurses, and we can help with this. We've got a telehealth service as well that is overseen by the nurses, and we're there to troubleshoot all of those things for those patients. And this was just also to show that there is a vast catheter range of intermittent catheters. And if any of you have any questions about anything like that, you want some more information, then the lovely Priya Kuna looks after you guys. And I've just popped her details up there, and she's going to be joining me now for the next 10 minutes or so, should any of you have any questions. So thank you very much for listening, and I hope you've learned something, and I hope that you found it valuable.
Thanks, Michelle, for that, and apologies to everyone that we lost internet connection for a few minutes in between there, but luckily we managed to get it back up and running, and thankfully it didn't hinder us too much. So now's the opportunity to ask the team any questions that you may have. Do put it in the Q&A box if you do have anything. What I'd also like to say is, before everyone goes today, if you could just rate the training in the Q&A box. So just a quick evaluation, rate it 1 to 5, 1 being poor, 5 being excellent, and then a quick comment as well around the training or anything around future training as well that you'd like. You can anonymise it as well, so you don't have to put your name down to it, and we, you know, it keeps it sort of so we don't know who's written what. So before you go, just type that in, that'd be great. So as I wait for any questions to come in, just probably worth us mentioning that Michelle and I and the team at Coloplast have had quite a few conversations around pathways and what pathways we've got in Greater Manchester and what teams are currently doing, etc. We did bring it to a recent meeting that we had a few weeks back across both inpatient and community neuro rehab stroke services, and it was agreed at that point that we needed to do something about it, a lot, you know, for the reasons that Michelle's touched on today, and allowing that continuity of care from inpatient into community as well. So we're looking at the moment to see if there is an appetite in Greater Manchester to develop some sort of pathway with standardised documentation, etc. So if anyone is interested that's on the call today, then please do bob me an email, bob Michelle an email, or Lisa, and we can sort of, the idea is in the new year we'll start a task and finish group and put some sort of ideas to paper and think about sort of next steps and things.
Jimmy, you've gone on to mute.
Oh, sorry. Don't know how that happened, apologies. Worth mentioning at this point in time that are there any sort of gold standard pathways or documentation out there sort of that are used nationally around bladder management or anything like that, or is it very much determined on a local level? I don't know who might want to answer that.
There are various different pathways around that people can follow. We do know that unfortunately, when you look at things like NICE guidance and various other guidance, we know there's lots of things out there, but we know that often they're just not followed. It's not that people don't want to follow them. We're quite aware that pathways are broken almost. Very often we find that people don't even know that they exist. So, you know, for example, on the acute wards, anytime when there's kind of training, it's really, really difficult to get hold of staff that are doing long days to upskill people. Before, when we had earlies and lates, you'd have that change over time when you could grab nurses, kind of upskill them, physios and OTs as well. And now it's just a bit trickier to get everybody in the one room. So we're finding that you know, there is a lack of cohesive pathway following, let's say, in many units, probably more units than none up and down the country. And it's why we're kind of working hard to come locally, because again, it's all very well having these national kind of policies and pathways. They don't always fit. They're often not quite right for every different unit. That's why I sort of use the Ayrshire and Arran one as an example. That's something that we worked with them to produce. You know, that one may not work for what you guys need. Different pathways are needed for acute versus an outpatient clinic versus what you guys have, which I think is a bit more of almost like a hub with various spokes coming into it. So I think it's always better if we get the guys that are on the ground locally. We put the heads that need to be together, and with a bit of help from us, as we have probably a little bit more time to work on the sort of boring parts of the pathway, let's say. You know, we can work together and come up with a document that actually is fit for purpose locally. I don't know if Priya's got anything to add to that, or Gemma or anybody else.
Yes, I'd agree, Michelle. When they're designed locally with input from all parties, and then we can also help with the implementation. I think the implementation is more key than bringing out the pathway itself, because if everybody knows about it and it's being followed uniform the trusts that it works in, it works fantastic.
And the other thing that I'd add to that actually is what we found, I'm sure Eshra and Aaron wouldn't mind me sharing this, but actually what they found is that it's put bladder and bowel at the forefront of their mind. So it was specifically designed to use in the MS service, but even now in the acute wards, they found that the nurses and the healthcare, other allied healthcare professionals are really thinking bladder and bowel. And I've come from Queen Square, the National Hospital, and I set up lots of kind of different little pathways there as well, and it's really made everybody on the ward think bladder scan, bladder scan, bladder scan. So it's just also having this in place just really kind of focuses people's minds on what they should be looking for as well, I would say.
Thanks, Michelle. So what I've done for everyone is I've just put my email address into the Q&A section. So if anyone is interested in being part of this Task and Finish group, then please do get in touch with us. And like I said, it's probably something that we're looking to start in the new year after Christmas. You mentioned then, Michelle, that, and I think Priya, you mentioned it as well, is that sometimes we know what needs to happen and what pathways should be in place, but it's the implementation bit, that's the bit that clinicians struggle with, to have the time and the capacity to kind of put that in place and talk to the powers that be, etc. Are you guys at Coloplast able to support them with that in developing local pathways?
Yeah, absolutely. Yes, we are. Like Michelle said, the advantage that we've got, knowing how busy you are and how stretched you normally tend to be as healthcare professionals, is we've got the time to do those little, you know, the boring bits behind the scenes, if you will, to get it up and running and to get it just designed how you want it. Then the implementation, 2 of the hospitals that I've worked with really closely, so I cover the whole of Greater Manchester and Cheshire as well, right up to Warrington. And the implementation normally tends to be a sequence of meetings held within the trust, where it's then rolled out as this is the pathway that's going to be followed. In terms of the smaller training sessions and repeated visits into the hospital, making sure that everyone has a copy of pathways. I mean, nowadays, there's something amazing being done in 2 trusts where discharge policies or pathways can actually be put onto the ward computers, so they're saved as screensavers. That's worked extremely well as well. But that sort of implementation and making sure that the meetings are organised and it's repetitive, so that we get around the whole hospital and everybody that needs to know is aware of it. I can absolutely help with.
And also it's about writing the actual pathway and policy, and very often as clinicians we know what we want to, you know, from the patient's perspective, we know absolutely what we want to do, but then it's convincing or writing it in appropriately as well for management to understand. And you know, we're great at saying, look, we know that there's a need here and it's going to benefit our patients, but realistically as well, from the management of the hospital, they need to see the kind of money saving and the cost saving side of it too, which is something that Coloplast have, you know, a big team of people that are really good at working on the figures and the stuff that perhaps as clinicians we're not best placed to do. So that's, I found really, really helpful.
Thanks, Michelle, and thanks, Priya. I'm conscious of time, and we said we'd finish it too. So if anyone does have any other questions, then please do put them in the Q&A box or bob me an email, and we'll make sure that we send them across and get you a response via email if needed. Just to thank you both for the session today, really informative and really useful, and hopefully it'll help us in gathering some sort of momentum as well from people moving forwards to make some changes
rangers across Greater Manchester. So thank you all for attending, and thank you for your time. And just a reminder to everyone before you go, just pop in a quick evaluation for today's session. It'll just help us with any future training events. And just a reminder that, as Michelle said, in 2 weeks' time, we have got the bowel management webinar that is going ahead as well. So nip onto our website. I'll pop it in the chat box, and then you can register there. Thank you, everyone.
Thanks for having us.